Thank you, everyone, to joining on this spring meeting. This is our first spring virtual meeting, and it's a special occasion because it's the 10th anniversary of the Ideal Spring Ideal meetings. I'm sure Hanya will say some more about that. We went for virtual to try and be inclusive, to include midweek participation. And just for the speakers, we are aware there might be patients joining, which I think is great because it shows the impact of Ideal. And we also plan to record the meeting so it's on the Ideal YouTube channel. So just be mindful of that. And finally, I'd just like to say thank you to Professor Rovers and Dr. Schultz, who also helped put this meeting together. And I will hand over to Hanny now.
Yeah, thanks, Hugo. And it's a real pleasure to speak to you all. Great. So I know some of you already. For those who I haven't met in person, my name's Hanny. I'm a consultant neurosurgeon at Queen's Square. I have a role in industry, which is a conflict, and I'm also the chair of the Ideal Collaboration, a role which I'm very proud of. And as Hugo says, this is quite special in that it's the 10th year since we ran meetings, but also the first virtual meeting like this. Of course, we did do that during COVID. And credit to Mariska for really driving this forward and Hugo for putting it together. In speaking about the next 10 years of Ideal, I think it's helpful to provide some context. And Buxton's law is a favorite amongst the Ideal circles, and one that I'd heard about many years ago, even before I joined Ideal. But it's this idea, very common amongst clinicians and particularly surgeons, that there's really no good time to do rigorous evaluation. Either it's too early or something's already adopted and it's too late. And as a result, I think for much of surgical history, there has not been good evaluation of surgical innovation. Many of you will know this very famous editorial in The Lancet by Richard Horton back in '96, the comic opera. And as a result of this, the Balliol collaboration, of which Peter, Jane, and others on this call were part of, put their heads together to try and think of a way to do surgical evaluation better. And there's a huge amount of careful thought that's gone into evaluating surgical innovations and complex innovations in general. And it's quite hard to distill it into the most basic concepts, but I've tried here. And I think at its most basic, and Peter says this often, the insight is this, which is that the evaluations you do vary depending on where you are in the life cycle of an innovation. And the most basic reductionist view on Ideal is that you have to at least have this prism of a life cycle for you to be really doing an Ideal-like study. And so if you have a very early surgical technique or device, we expect and anticipate a learning curve. Of course there will be, and there'll probably be iterations. And the focus is around showing that it's safe and feasible and documenting carefully those variations. If you're at a stage where you've got a stable intervention, then you can do a randomized study. And once you have a device that's out there, you can do evaluations in the long term. And so having a staged evaluation of any technique or technology is really the crux of Ideal. And I would add that there's a second dimension in my mind. I'm biased because it's something that I thought a lot about for a few years. But alongside this timeline in one axis, I think it's worth considering perspectives of the different stakeholders in the other axis. And so for many things, but not all things, they would be a device perspective, a patient perspective, a clinician perspective, is it clinically usable? And finally, and often least thought about, a system perspective. Is there a chance that this could be cost effective? Is there sustainability questions, which is particularly pertinent these days? And I think having both of those in mind when considering where Ideal will go is very useful. Now, so some of you have been involved with these projects, and of course, a big part of Ideal in recent years has been to apply the framework to contemporary innovation, and that is in surgery robotics and AI in healthcare more broadly. And I'm very proud to have been involved with some of this. Um, but I think it shows and demonstrates the real value and generalizability of the framework, that iterations of the framework can be used in these quite diverse settings, quite different to when it was conceived 15 years ago. In the last couple of minutes, and I'm conscious Hugo will keep me to time, I'd like to talk about what I really would like to see over the coming years. And in some ways, this is easy. It's more of the same. Of course, we would like to continue to apply the framework to new technologies as they emerge. Some of the things we're already looking at include the use of IDEAL to assess training, the use of IDEAL in global surgery, which is a very, very important consideration in these days. And finally, and this is something Hugo really leads on very well with Arsenio, the use of IDEAL for neurotechnology, brain-computer interfaces, things like that. And so as these new technologies, innovations emerge, yes, we do want to apply IDEAL and create frameworks around those. But I think the real goal is a bit more simple, but in some ways more challenging, which is really what I want, is for people to use IDEAL everywhere. In any evaluation of surgery or complex interventions where IDEAL is suited, we want to ensure that people are aware of and getting the support to use IDEAL. And that means IDEAL in lots of papers and being used by industry. It means the advisory service, which Peter, Simon, and John lead, really helping people through that pathway. But most of all, it means having lots of people helping drive this work. And I'd like to draw attention to a couple of things which I'm excited about. One is being led by Shiraz in Oxford, and that's around this concept of the quality of an operation. You feel like it's analogous to the dose of a medication and it being delivered. And I think that has a really important role to play in how IDEAL might be used in the future, that you'd be able to quantify how a surgery was delivered. And we've done lots of work in our group, others have done the same, on trying to use surgical video and using AI to parse surgical videos and try to provide some feedback to that end, similar to compliance for drug trials. The other thing I really want to emphasize as a good direction to take is the great work being done by Jane's group at trying to kind of operationalize IDEAL and picking out examples of innovations and how exactly we can better incorporate the framework in those case studies, and where we can do better, where we can help iterate the framework and provide better guidance to make it easier for people to use the framework. And I think with that, I will say thank you and conclude.
Thanks. Perfect. So I don't think Professor Campbell needs any introduction. She's Professor of Health Services Research at the University of Aberdeen and also the Director of the RCS in Aberdeen Surgical Trial Centre. And we're very excited to hear a very hot topic of the impact of Bayesian on surgical trials. So thanks, over to you.
Thanks very much for the invite now. And yeah, thanks very much for, again, coming to speak to IDEAL. I mean, IDEAL is close to my heart. Love to see that photo of Balliol. It feels like a lifetime ago, and we were young when we were there. But anyway, yeah. And I think I want to just spend the next 15 minutes talking about what is a hot topic, and a topic I think is going to be very much part of the future, and very much one that I think the IDEAL framework and collaboration can really gain from. Just some disclosures. That's fairly straightforward. I think they've already been mentioned. And so I want to do a bit of background, the one we're all familiar with, the frequentist paradigm. This is where we all stand at every trial, every study pretty well that's published, is all about p-values, and it's very p-value driven. And sadly, it's become very dichotomous in terms of the interpretation that's made around studies. And, you will find that studies are either now just said to be significant, there's a significant benefit, or it's not significant. And, you know, we drive our sample size calculations to inform these p-value decisions. And if our studies are small and they're underpowered, the reality is we'll get a non-significant result, immaterial of how potentially high the effect size is. So that's been the tradition for decades, really, and it still holds a very tight grasp on the world of evaluation. But the Bayesian paradigm is coming into play, and it is totally different. So I thought I'd spend just a couple of slides just getting everybody up to speed in the Bayesian paradigm. So it's a probability-based decision framework. So we start with an initial belief or an initial set of evidence about an intervention, a surgical intervention that's called our prior, and I'll come back to the priors. And then we update our knowledge base in the light of the new data that we're collecting. And so it's very iterative. So every single data point we collect in a study or a trial or whatever, that is used to then update this original estimate or belief we had about an intervention. And so at the end of the day, you end up with what we call a posterior probability, which is the probability that the effect of an intervention is beneficial or not. So we might find at the end of a study, we come up with 91% probability of benefit or 80% probability of benefit or something like that. And we don't see p-values anywhere. So there are no p-values, and there are no dichotomization into saying this study is significant or not. We work with a very intuitive a very intuitive system that I think many of us are familiar with in decision making, is balancing these probabilities and what they mean. So this is just a basic concept that sort of distribution on the left is our prior beliefs. We have some evidence, we have some data, we can define that. And then on the right, we collect some data. And then the posterior belief or the posterior probability is basically what the body of knowledge looks like after we're added in the data. So as you can see, it shifts, moves along, but doesn't move quite as far along as the individual study itself. So the whole Bayesian framework is gaining a lot of traction. This is just a screenshot I pulled from PubMed. So this shows the really steep rise in the number of Bayesian trials publications, and I'm purely just looked at trials here. And as you can see, in the last sort of decade, and certainly in the last few years, it's just ramped up. And all of you who watch the FDA, so they last month published new guidance on the use of Bayesian methodology in clinical trials. So there's been a little bit of a ding-dong for a number of years as to how acceptable Bayesian methodology is to the FDA. And it's really helpful guidance come out about how to present Bayesian methodology and what's important to show and what is not. So again, just to get everybody up to speed, I'm going to spend a couple of slides on this key concept of the prior. And we have two types that we use routinely in Bayesian approaches. We have what we call uninformative or minimally informative priors. And then we have the other concept, which we call informative priors. So many studies use what we call these uninformative or minimally informative priors, and they are specifically designed to have very little impact on the analysis. They allow the data in the study or the evaluative study really to speak for themselves. So that picture we had earlier of the prior distribution, it's usually very flat, it's centered around no effect, so that actually the data are driving that posterior probability we get at the end. However, we also can have informative priors. And this is where we actually generate prior evidence or prior data. We can use previous literature or previous studies to inform our current state of knowledge about an intervention. And this is, I'll talk later about this, may be particularly relevant to ideal studies, where we might use earlier studies in that life cycle to then inform the later ones. We can actually generate a prior just using assumptions. We don't even need any data, or we can use it on clinicians or stakeholders' beliefs or experience. And part of the lingo is they can be positive, so they think the intervention is likely to be beneficial. That's enthusiastic. Negative, an intervention is unlikely to have a big effect, skeptical, or neutral. And so the real added value of making these sort of evidence-based or data-driven priors is that they make the trials informative, but they also make it more efficient because it's basically adding more evidence into the decision-making pathway. As you can imagine, there's a lot of discussion about priors. Should we use uninformative? Should it be informative? What should we do? And this is the main chat that happens around the start of a Bayesian study. If we want to do a Bayesian evaluation, it needs to have a very carefully considered process, justified and transparently reported, pre-specified. You know, you obviously need to understand the quality of the data and the information that's loading into the prior. And if you read the FDA guidance, sometimes you will have to discuss with the FDA, you know, what you're anticipating putting in your prior if it's being used for a regulatory approval. But that's all surmountable. And most of the time when you're generating a prior, you go through this process anyway. So it's very transparent to share that with the regulator. So I just wanted to kind of bring this to life a little bit and how it might be useful, particularly in surgical trials, but really in any trials that have these two scenarios. So one is a situation where a traditional frequentist trial would be difficult. That's generally when it's small, and we often see that in surgical scenarios. It can be looking at a very narrow eligibility group. And then the second one is scenarios where we can incorporate information from previous studies. So here it might be earlier studies in the ideal framework to then add value and add power into the later studies down the line. We can use data from a 2A to fulfill a 2B, or data from a 2B to then add extra weight to a phase 3. So I'm going to give a couple of examples here, starting with that first one, traditional trial being difficult. And I'm going to use the example of a study that I was co-chief investigator on. It was looking at a device. It's called the UK REBOA trial. And basically, it's looking at the effect. It was looking at the effectiveness of a REBOA balloon, a catheter, for the management of sanguinating hemorrhage. So people are bleeding out. Is it better to feed a catheter up through the femoral artery, go above the bleeding site, blow up the balloon, therefore, you know, stopping the bleeding, and then that acts as temporary control until you can get them to theatre? Or should you just not do any of this and take the patient straight to theatre? And so this was published in JAMA a couple of years ago. And I'll just walk you through the kind of decisions and the discussions we had. So this was about to be introduced into the UK NHS. No evidence. And then it was the Buxton's Law. You know, it's always too early to evaluate till suddenly it's too late. And we were having this major discussion. But then we looked at the registry data on these particular type of patients that were trauma patients and found there were only 60 to 90 in total across the country, maximum if we even got every single patient that ever possibly required this. And so we reckoned it wasn't possible to plan a large traditional frequentist trial. And so we looked, what could we do? And there's a really nice paper about how do you design trials in smaller populations by Max Parmer and colleagues. And there's basically three options. You reduce the power, which didn't seem reasonable. You increase the minimally important difference we were looking for, and that just didn't make sense. Or we actually forget the whole traditional frequentist framework and we move totally to a Bayesian approach. So whatever data we'd be able to collect, we would be able to say something about it. We would be able to come up with a posterior probability of benefit. Yes, there would be wide confidence around that, but we would be able to give decision-making evidence for clinicians and for policymakers to work on. So we had a lot of discussion about a prior, and eventually we decided to use that minimally informative prior to let the data speak for themselves. We did a sensitivity analysis. We also generated an informative prior. So there was very little robust evidence out there, so we couldn't do a data-generated prior. So we actually did a stakeholder elicitation. I've said clinician here, but it was actually clinical and patient experience. And so we actually did a walk through with them online and generated an empirical prior distribution. They were of the view that Reboa would be beneficial, so our informative prior was enthusiastic. So we could also then test out what effect this would have on the analysis. So let me walk you through the results. So we compared SC as standard care, and then SC plus Reboa as standard care plus Reboa. And we were looking at 90-day mortality. And so in standard care, we recruited 90-odd patients over the timeline. In standard care, our mortality rate at 90 days was 42%. And unfortunately, the mortality rate in the Reboa group was actually 54%. That was, significantly, and I'm using that in the English term, substantially higher mortality rate in the Reboa group. The odds ratio for harm was above 1, it was 1.58. And as you can see, looking at the 95% credible interval, wide. So in the traditional world, if we ever was in that, non-significant. So you would just say there's no evidence of effect at all here. But the posterior probability using a Bayesian approach gave us 86.9% probability of harm. That was it. And for all the clinicians round the table, that was highly convincing evidence that you would not introduce Reboa into the UK NHS with a 96.9% probability of harm. So again, traditionally non-significant, but definitely giving evidence for decision-making. And here you are, this is just the picture we had, the green thing is the very flat prior, and then the the distribution is actually what we saw, and you can see 86.9% of that distribution is on the side of harm. So it gave us clear results despite small numbers, and in light of a traditionally supposedly non-significant result. Probability of being harmful was 86.9%. The other thing I didn't tell you was the probability that Reboa was actually beneficial was 3%. Absolutely bottomed out probability. We also looked at what the impact of the informative trial would have. It attenuated the results slightly. If you remember, they thought positively about Reboa. So the probability of harm came down a little bit, but not a lot. 81% still highly convincing. So I think you'll see there that it really does provide really good advantages in scenarios when numbers are small, which is often the case when we are developing and evaluating early doors in a trial of a surgical event, a surgical procedure. So let's talk about the other one. So this is technically, the term is called Bayesian borrowing. So what we say here is, can we use some of the evidence we've collected in previous study to augment a down the line study and give it more power? So yeah, can we use data from previous studies? That's where the borrowing comes from. You're borrowing strength from previous studies. It obviously needs to be justified and transparently reported, and you can downweight a bit of the impact. But I think this could potentially be really useful in the ideal framework as we're generating this cumulative evidence base of knowledge. So the trial I'm going to show you here was one that was published towards the end of last year. It was, again, I wasn't involved in this one, but it's called Rescue 3. And this is taken from critical care. So this is a device that stimulates your diaphragm if you're in critical care and mechanically ventilated. So many of you are aware, if you're in critical care and being ventilated, then you have massive loss of muscle mass, and your diaphragm in particular is very important for helping you to be able to breathe on your own again afterwards. So the idea being that if you stimulate the diaphragm, you'll be able to keep that muscle mass there. So is it better to neurostimulate the diaphragm, or is it not? And so what this trial did, it used a Bayesian approach, but it borrowed prior information from a previous phase 2 trial that they had done of the technique for proof of concept. That's the RescUE-2 trial. So 223 patients were randomized in their phase 3 study. So as I mentioned, they generated a prior from actually a subset of the phase 2 trial. They only identified the patients who best matched the phase 3 eligibility. They actually did a bit of down weighting, but then they looked to see what was the effect of the intervention with or without the influence of the borrowing. Without borrowing, they showed that the technique was, the probability of superiority of treatment was 91.5%, pretty high. But once they added the borrowing from the prior probability, the success criteria had moved up to 97.9% probability of benefit. And they calculated that the added power of borrowing information from the previous study was equivalent to adding information from an extra 64 patients to the downstream trial. That's a lot of extra information. So you can see this allowed the downstream study to be much more powerful and also allowed the cumulative picture to be seen rather than each study in isolation. And to me, this speaks a little bit like meta-analysis. It says, what do we know in advance? Add in the data from the trial, and what do we know afterwards? And so, to me, actually, a cumulative picture can be more powerful than the individual trial. And here, again, you just see the graph of that. It shifts along slightly in the light of the positive evidence. So just a couple of slides to wrap up. Consideration for Bayesian trials. It uses information in a cumulative way and makes it more efficient. To me, it fits in with the ideal approach of a systematic development. Each phase builds on the earlier work. It's definitely allowable in the FDA guidance. You may have to have a little bit of discussion about the prior, but obviously it's going to be subject to greater scrutiny, needs to be justified, needs to be transparently reported. You obviously need to do a lot of design work and show that in advance. But actually, for me, I think Bayesian approaches to trials are very powerful. They allow flexibility compared with the traditional approach. It allows every data point you collect to count, and it can support integration of data from previous studies, for example, from earlier ideal phases. It still needs a paradigm shift. It needs a skill shift. Half our statisticians don't know how to do this. We need to ensure they do. It needs education, clinicians, journal editors, and so on. But despite this, I think this will be the future. And I'm just going to leave you with a slide, a bit further reading if you want to look at that. These are generally written, a pick 2 written by Ewan Gallagher, clinician. So it's a clinician writing for clinicians, so hopefully it'll be understandable and easy to read. And also, actually, the FDA guidance is actually a reasonable read. So if you want to go and read it, I would suggest you do. And on that note, I'll leave it there.
Okay, thanks. That's amazing oversight and helps clarify a lot of some of the discussions that we've been having. Does anyone have any questions, Professor Campbell? We have a couple of minutes.
Thank you so much. This is Pedro Ramirez. I'm in Houston, Texas, at Houston Methodist. Thank you for your presentation. Really very, very interesting. I just had a question with regards to the Bayesian methodology as it pertains to in surgical trials. There is a progression in terms of learning curves, and do we run the risk of pulling data from a novice versus a mature surgeon as you're doing this analysis?
There is always that risk, but I mean, I glossed over a lot of the technicalities, but the down weighting of that prior information will help you in that scenario. It means that you can actually not make it quite as extreme as the data would suggest. So you would always pick from the earlier studies, you would pick probably from the more mature surgeons' data to then inform the later phases. So you can be quite selective what you pick and what you put in the prior as long as you're transparent. But I think there are ways in which you can avoid being pulled back by the very sort of ones at the very early stage of learning phase, but still get the benefit of the Bayesian approach.
Great, thank you.
Hi, Maria. So thanks for a brilliant talk. I hadn't heard about Bayesian borrowing before. I'm interested to learn more about that. But I wanted to ask you about an idea that's been around for a long time about Bayesian, which is applicable to IDEAL, which is Richard Lilford's recommendation that repeated Bayesian analysis would be a good fit for small studies such as IDEAL 2A studies, because you can reevaluate with every case. And you can, as you described very well, you can end up saying something instead of nothing. And you can end up with greater and greater confidence as your case series goes on. So I just wondered if you could see any downsides to that proposition or any reason why it hasn't really been done very much.
I mean, that's essentially the methodology behind Bayesian is you can stop it at any point in time once you add every data point updates what we know already. I think probably I guess my only comment on that will be very marginal changes potentially with a single case. So what we tend to do in the main Bayesian trials is have much more interim analyses than you would normally have in a standard frequentist trial. You'd have multiple interim analyses, so you'd be looking often, and there's no penalty for looking often in a Bayesian trial. So maybe not every case, but it would certainly be very, very often. And we did that in the reward trial because you need to look for harm. And it actually was stopped for harm in the end because we had these multiple interim looks. But the extension of that is every case. I just think maybe there's not a lot to be had from the poor statistician analysing it every time.
Oh, well, we've got to earn your crust. But
absolutely.
I think it's a great thing compared to the frequentist approach that it doesn't matter how many times you look at the puzzle. You're not interfering. You're not getting into the same situation as you get with a frequentist approach. Whereas if you ask it the question often enough, you're going to get one significant result.
Yeah.
Perfect. Thank you. On that note, I think we might move on to the abstracts because I'm just mindful of time. So thank you so much, Professor Campbell. That's brilliant. So for the abstracts, we've got 4 varied talks, and the presenters will have 7 minutes to deliver their talk, and we've left 5 minutes for discussion. And this is a really good opportunity to leverage some of the ideal minds that are kind of really behind the collaboration. So do think of some good questions. And without further ado, we have Dr. Bradley Guidry from New York, who will be discussing standardizing outcome reporting and technique variations in nipple areolar complex neurotization after nipple sparing mastectomy.
All right, good afternoon. My name is Bradley Guidry. Obviously, I'm a surgical resident in New York. Excited to speak to you guys today. Thanks so much for having me. I just want to speak a little bit about our ideas at Maimonides, my hospital, on using IDEAL to inform and structure the development of nipple areolar complex neurotization after nipple sparing mastectomy. I have nothing to disclose. So a little bit of background. Nipple sparing mastectomy is an oncologically safe procedure for selected patients, and its use is actually expanding. From 2005 to 2015. Patients undergoing mastectomy with NAC preservation increased from 1.7 to 14.3%. Despite these advances in NAC preservation, up to 80% of patients still report sensation changes postoperatively. Additionally, 80% of patients identify nipple sensation as an important outcome. This has created a demand to develop procedures which improve NAC sensation. This is just a little background anatomy for anyone who's not familiar, but sensation to the complex is supplied mainly from cutaneous branches from the 4th intercostal nerve, with some input from the 3rd and 5th as well. These branches pierce the chest wall laterally, but anterior to the serratus anterior, and travel through the breast parenchyma and have to be excised during mastectomy. Current body of research is fairly limited, with the earliest description of this procedure being in around 2019. Some groups are using neuroorthy, this group out of Taiwan especially, which involves meticulous dissection of cut lateral cutaneous branches of the intercostal nerves proximally to the intercostal nerve itself, with further dissection of the intercostal to achieve adequate length to implant it underneath the nipple areolar complex. The other main group is Pele et al. They're using a nerve graft. So interoperatively, they identify the cutaneous branch and actually attach a graft to the intercostal and connect it to the base of the nipple. Pele et al., their most recent results provide a 66% excellent sensation at 6 months in their patient population. So it does show some promise. However, there is lack of standardized outcomes. Chang et al. Uses monofilament testing, whereas Pele uses a proprietary system. It's called the Actable PSSD, which is a pressure specified sensory device, which is very expensive, costs about $8,000 to $15,000, but does provide a little bit more granular data. And then there is subjective data, which is usually monitored via the BreastQ database, which is a validated subjective outcome. And all of the research, unfortunately, has very small sample sizes. And whenever you kind of pair all this together, it kind of describes a 2A study, which is still undergoing some technique variation. So through the lens of IDEAL, we can identify which types of studies are needed to efficiently progress this procedure to maturity. These studies should have prospective design and meticulously document technical variation. Standardized framework for reporting results allows direct comparison between techniques. For example, the two studies I presented earlier, there isn't a great way to really compare their objective metrics, considering one is using this special device and the other one is using just binary monofilament testing. Another issue we've run in with our own patient population as we're kind of developing this procedure at my institution is that we're having an issue with insurance approval. There's only a few insurances which will approve the added cost of the nerve grafts, which creates some inherent selection bias in who receives this procedure. And in order to broaden the patient selection, research groups would therefore have to find funding from either the industry, such as the graft manufacturer Axogen, or receive research grants, which can be a little bit cumbersome for smaller groups. So making a clear, accessible database for groups to track these results will allow non-funded groups to pull data without the need for industry financing, which we know introduces bias. What we're hoping to accomplish, our database will hopefully allow for stratification of technique and correlate outcomes with operative variables. We hope to identify the most cost-effective and reproducible approach down the road once we compare these techniques. And this will facilitate a focus towards IDEAL stage 2B studies, which require multi-center prospective data. Standardized reporting will allow for pooled data, not limited by bias of industry financing, which will produce high-quality literature and hopefully convince insurance companies to expand access to the procedure, which will then result in wider adoption and improved outcomes in the patient population. So this is kind of what we've come up with. Our proposed database will include operative patient characteristics, as well as quantitative and qualitative outcome metrics, which were agreed upon by a consensus of our breast and plastic surgery group. These were chosen based on prior research seen among the breast, plastic, and peripheral nerve surgery literature base, with outcomes being chosen based on accessibility and with a low-cost barrier to ensure that the database is accessible by all performing this procedure. Again, for impact, we're hoping that if many groups are able to adopt the same structured database, it allows for easy, direct technique comparison to quickly refine the procedure. And through this, we can identify the most cost-effective and reproducible approach. We hope adoption will will allow for pooled data, which will produce high-quality literature, which would in turn convince insurance companies to expand access to the procedure, resulting in wider adoption and improved generalizability of the research. And this would facilitate focus towards IDEAL stage 2B studies to mature this technique. With that, I want to thank you guys again for the opportunity to present. I'll take any questions.
So I'll start then. How many of these procedures have you introduced in your unit?
So overall, we have 2 of our plastic surgeons are, I guess, trained to do the procedure. They were actually trained by the graft manufacturer. We've done probably about a dozen in the past 3 years, and we're trying to look to expand that. Like I was saying earlier, we've run into troubles with patients who qualify for the graft itself with actually funding and getting insurance approval to perform it, which is probably a pretty commonly encountered problem in early studies like this.
Okay. And how are you, in terms of the technique maturation and the learning from those 12 cases, how are you evaluating that or recording that across the consequent cases?
So we haven't really had any variation. I think one of the issues with graft use, which is what our institution performs, is that it takes up to 12 months to see some benefit. Depending on the length of the nerve graft, nerves usually regenerate like 1 to 2 millimeters per day. So if you have a 6 centimeter graft, and that's going to take 60 days, and that's on the lower end of the length that we would actually use. So without seeing the actual output of results, it's hard to kind of vary our technique. So we haven't, I guess, all that to say, we haven't really varied our technique to kind of document it, if that makes sense.
Perfect, thank you. Kerry, you have your hand up.
Yeah, thanks, Brad. That was a really interesting talk, and I think it's a really commendable aim to sort of develop a standardized outcome set, and it's clearly going to be really important from what you've described. Just wondering about getting people to use it. Having developed core outcome sets myself, sort of getting people to use it is the next step. And I just didn't know if you had any ideas about sort of how to encourage people to use the standardized set of outcomes that you've developed, and what might be needed to help them do that.
Yeah, so I guess it's similar problem to IDEAL itself, is like kind of getting the word out there. I think identifying groups that are actually pursuing this and reaching out directly, it's not that infeasible of a way to approach this, considering there are only a few groups performing it. That being said, trying to create a publication that lays everything out, makes it accessible to groups that would be looking into performing this procedure, and maybe even reaching out to Axogen or people in the industry who are developing the graphs and things like that, to kind of point groups in a direction of using this database so that we can kind of collaborate with data.
Yeah, I think that'll all be really important. And previously we've sort of reached out to journal editors as well, so that when protocols and at the time of conception of studies and things, when protocols are submitted, they're aware that there's a sort of standardized outcome set being recommended, that they can sort of look out for and check to see if it's being used. But yeah, sounds brilliant. Well done. Yeah,
that's a great idea. Thank you.
I guess I just have one final one then. So the company that's making the graphs, is that specific to that type of surgery? Because it seems, if it's a relatively new type of operation, it seems a niche area to go into for manufacturer or industry, if it's not that commonly performed. So the total accessible market is probably limited.
Yeah, I actually don't know if this nerve graft is the same nerve graft they use in other peripheral nerve surgery. I would imagine so. I can't imagine a nerve graft would be designed specifically for breast nerves. I would have to look into it, though. I don't know the answer to that question.
Okay. All right. Perfect. Thank you. I think with that, we're perfectly on time, which is great. So we'll move to the second abstract of the evening, which is Mr. James Oliver, who is at the University of Bristol. And his talk is Operationalizing Modification Reporting Alongside Ideal Guidance, the SMART Checklist for Surgical Innovation. So welcome and thank you.
Brilliant, thanks. Let me know if you either can't hear me or can't see the slides. So yeah, thanks for the invite and thanks for the excellent program tonight. I'm James from Bristol, talking about my work from my doctoral thesis around surgical modifications to surgical innovations with the Bristol group. So just briefly, what I'll be talking about is why we undertook this work, what we did, what we produced, and then what we're going to do next. Don't need to tell you all that surgical innovation is very important to improving outcomes and care. We all know that. And the process of innovation, as demonstrated earlier in talks, revolves around iterative improvements and changes to devices and procedures. IDEAL has long recognized the importance of modifications in this process and of reporting them. But we can see in the literature that the way this is done is variable and sometimes insufficient. And that may be due to a lack of clarity on or a standardized approach on exactly how to do so. So we're aiming to fill this gap by addressing this through our research. So several phases to this research. The first is a very large or reasonably large systematic review of 104 papers with an in-depth qualitative analysis. I presented this at IDEAL before and it's published as well, so that can be seen separately. The summary is the modification reporting was very variable and sometimes insufficient, although we did see some good evidence of particularly good practice, which we've used to develop a provisional reporting checklist or reporting guideline on how to develop and report these modifications. We took this forward with lots of in-depth interviews, so with 20 stakeholders across the UK, clinicians, surgeons, methodologists, trialists, medical device experts, and then individuals who work in a professional capacity around regulation and governance. So we use this to iteratively improve that checklist and refine it to a point where no further suggestions were being made. And there's a group of stakeholders and a research team who were happy that we had a finalized product, which I'll go through in due course today. So just to explain what it is, you would use it when you're publishing your period of innovation. So when you come to write your manuscript after your period that you want to publish, you would use this to structure your approach to reporting modifications. And I'll go through each section in a short while. So it's similar to things like the CONSORT checklist or COREC or many other ones that you'll all be familiar with. It's specifically designed around innovative and invasive devices and procedures. Can be used by anyone who's been involved in that process. So be it a clinical member of the team or non-clinical, academic methodologist, industry professional colleagues. And then you would use it alongside and in conjunction with IDEAL. So it would complement and add to IDEAL. And you can use it anywhere in the innovation lifecycle. That's the purpose of this, to be broad and applicable. And we've made sure that's really pragmatic and straightforward to use. And indeed, that was the feedback from the vast majority of stakeholders, that this is not going to add to research burden, yet it's still comprehensive and adds to the improvement of quality of modification reporting and surgical innovation reporting. It's in 3 sections, which I'll go through briefly now. Will be in detail because obviously this is going to be published separately and we're limited with time. But the first section is around the starting point of that period of innovation. And so on the right, you can see a column where it says page number. So the author would simply put, this is in the introduction, so that'd be page 2, for example. So the first point is just describing the innovation. So it's constituent comparts or steps. And then there's a definition of what we call surgical innovation, because obviously that can not always be straightforward. And then we talk about which patients are included at the start, so the intention of which patients or indications, and then where it is in the IDEAL framework. And then number 4 is around the context. And many of these things you'd already be reporting anyway, but it's just getting it very clear so you know the starting point before anything changes. So that's the first section. And then this is the second section, very busy, text-heavy slide, don't need to read it. It's all going to be published separately. But this is really the main chunk of the checklist around the actual modification. So these are split into technical modifications, 5A, and for procedures or devices, and it lists some examples there. And in the manuscript will be additional examples. And you'll see on the right, there's 3 columns. For each modification, we want the authors to say when they used it in the process, why they used it, and the outcomes of that. So for example, an additional laparoscopic port, because a particular part of anatomy was difficult to get to, and the implication was it was much easier to do that part of the dissection, for example. Then 5B is around which any changes to the patients involved in the process. So that might be a change in the BMI cutoff or comorbidities or the particular pathology location, for example. And then 5C is around whether this had to be stopped or converted, or a different approach used at any point in the time frame as a sort of significant modification. And then finally, 5D is where no modifications have occurred. So interestingly, there are a couple of papers in the 104 papers we looked at which said that we had no modifications during the process. But then there were a huge number that didn't report any modifications, but equally didn't say there were 0 changes. So I think it's really important to know that this has been changed during the procedure and then what's been changed. And equally, if it's a very stable or simple, straightforward procedure that doesn't need to be changed, or device that doesn't need to be changed, that's really important too. Finally, the last couple of points, the third section here is around the stability, the end point. So when they've got to the end of their study, how stable is that innovation? Are they going to change it in future? Any anticipated changes? And then finally, I think really importantly, any learning points from this process. So what have the authors learned that other people can learn from to save? The research ways to save people repeating, detrimental changes, but equally to learn from beneficial or advantageous changes to the procedural device. And as you can see, it's all very straightforward, one page, simply to put where it is in the paper. Next steps are, we currently are testing it with some innovative case studies that we have networks through from our units. We're developing a publication that's in hand at the moment, and then dissemination will be the next steps to improve implementation. And finally, later down the line, we'll look to reevaluate this and iteratively keep on improving it as we go forwards, perhaps expanding its indications, for example. So thank you very much. Happy to take questions, equally happy to receive emails about this if anyone wants to talk further.
Perfect, thank you. Brilliant and well kept the time. Does anyone have any questions? Here we go. Professor Rovers.
Thanks for this nice presentation. And I see how important it is, but maybe we have the same question as Carrie asked to Brad. Although you said something about dissemination and implementation, but we know that the ideal reporting guidelines are already not implemented or used by the surgical journal. So how are you aiming to get this? Because you said it's an add-on. How to get this add-on as we don't use the ideal reporting guidelines yet?
Yeah, absolutely. And I think part of it is there is an element of checklist fatigue and guidance fatigue sometimes. So I think it was really important that we made this straightforward and simple to use. So when we started, this was much longer, 2 pages worth. Lots of points sort of came out during the process that were less important or perhaps ambivalent or difficult to understand. And so we also held a large workshop with an extended group of colleagues in Bristol from different departments to really optimize this and talk about dissemination plans. And we spent an hour workshop on this just to work out what the next steps will be, because I think that's absolutely important. It's there's no point doing this work and then it not being used. And then also I think part of it will be evaluating how it's used and any sticking points. So this is what we're doing with this prospective case studies now, to see how it's actually implemented and whether there's anything we can do to enhance that alongside dissemination plans.
And James, will you then disseminate it on its own or together with the ideal reporting guidelines? Because you started off with saying it's an add-on on the ideal reporting guidelines. So will you disseminate on its own or together with the ideal reporting guidelines?
Definitely. So definitely planning to publish it as a checklist, with discussing it that it can be used alongside ideal. Of course, happy to collaborate with ideal going forwards and keen to know people's thoughts. But yeah, we have our established networks and of course social media presence through our units that we will then also disseminate this work through.
Brilliant, thank you. I wondered, I hadn't seen the definitions, but how do you define modification? Yeah,
it's really good question. There's lots of terms that we use that are sometimes difficult to determine really. So innovation, as we all know, itself is a slight can of worms, and modification itself. There's actually no established definition through research, and that was part of looking at this. And so we've just taken a really broad approach and asked people to identify anything that they think is vaguely changed whatsoever, be that potentially a major or minor modification, to really enhance learning from other people, because I think ultimately everyone's definition of modification is going to be slightly different, and there's no established agreed upon definition. So we have to be really pragmatic with it and just try and include everything so that people can learn from that process.
Yeah, I think it's a brilliant addition, and I think similar to the previous discussion, is that the adoption of it can be challenging, because even as people that believe and use Ideal on a regular basis, even getting uptake for people to use Ideal and to understand what stage of Ideal their study is requires quite a lot of learning and complex understanding. And so this almost takes it further to make someone understand that they are changing the agreed procedures. But even with procedures, there's no kind of gold standard for most of them on how to do it. So therefore, understanding if you are then modifying it, how am I modifying it and why am I modifying it? It becomes, I think, quite challenging to break down operations into those kind of very basic steps and then realize that you are modifying it.
Yeah, no, absolutely. I think it's about not just saying this is a finalized product that we did all the way through, but actually, being transparent and saying this is really important to know so that other people don't replicate mistakes.
Yeah, perfect. Thanks. Rhiannon had her hand up first. Please, I'm afraid.
Thanks. Just a comment, really. I'm in the same centre where James works, and we've been working on this. And it's really interesting what you said about how do you define a modification. We've got some really lovely quotes from some of our case studies where we've been following innovations where surgeons have said things like, oh, it's not a modification, it's just a refinement to the technique or a tweak after I'm comfortable with the procedure. So it really highlights actually that, first of all, it's educating or making people understand what modification actually means, and then using the checklist appropriately. So yeah, it's really interesting.
Yeah, absolutely. And I think that ties into the broader sense of Ideal, which is the ultimate is safe translation, which is transparent and kind of some agreed language, which is super challenging. And I think the aim is to try and reduce some of these, rogue surgeons or these terrible situations that you hear in the press of someone just making this kind of unilateral decision to change a procedure. And I wonder if something like this could be adopted by the local committees who decide if you can do a new procedure or a new operation. Because when you're speaking to the chief medical officer of a hospital or a research committee, and you're a surgeon talking about this very niche procedure, they don't really have the full understanding of what that entails and what the risk looks like for the patient. But if we find a successful system such as this to describe those iterations in a safe and transparent way, there's definitely value there.
I agree. Yeah, thank you very much.
Thanks, James, that was brilliant. So moving on to our third abstract, says Dr. Rhiannon Masefield, also from the University of Bristol, minimizing harm and bias in surgical innovation, developing the Lotus design framework to safely adapt patient eligibility criteria in early phase studies. Thank you very much.
Yeah, many thanks for the opportunity to present. So my name's Rhiannon Masefield. I'm a research fellow within the Centre for Surgical Research at the University of Bristol. Just to say thanks for the opportunity to talk, and I'm presenting on behalf of the team, so you can grill us all on questions at the end. I'm going to talk about one of our current studies, which is developing a framework to safely adapt patient eligibility criteria in early phase studies of surgical innovation. So I think, the audience that we've got tonight is very familiar that evaluating surgical innovation can be challenging, not least because innovations evolve incrementally, little by little, through iterative modification as they're being developed and used in real world practice. Ideal has obviously made some fantastic advances to address the issues that we get really in early phase evaluation to promote safety and minimize harm. But within our research centre, we've been studying case studies. We've been studying surgical innovation for more than 10 years now. And what we're seeing is that there are still significant challenges, and particularly around addressing surgeons' uncertainties around patient selection as innovations are progressing through that kind of ideal pathway. And Ideal really understands and really demonstrates how important patient selection is as we go through the ideal phases. And here's just a summary of the ideal framework that demonstrates number and type of patients and suggestions or recommendations of how that changes and evolves through the different phases, from the very early case studies where it's just usually one patient that's very highly selected, and then progressing through to stage 2A, where the number of patients typically would increase, but still just a few and very selected. And then as we get to stage 2B, the number broadens and increases, and to include more potential beneficiaries before we get right to kind of the evaluation study designs, where the patient numbers are much more increased and the kind of type of patients are expanded and very well defined. But what does that really look like in practice? And what we've learned from our observations and our studies is that actually it's really difficult to kind of apply this, as we've talked about already tonight, and how to apply this in kind of real life studies. And the reality is it's not quite so neat and tidy like you would like it to be, and like we'd like that framework to look. And unlike drugs development, where there's often pre-specified patient eligibility and protocols, or the use of screening logs are required, in surgery we don't see that quite so often, unfortunately. And there is flexibility for different surgeons in different centres to try innovations in different patient groups with much less scrutiny. And what we've learned in our observations of the case studies is that the decisions about choosing which patients to approach for the new procedures is often influenced by informal thinking and sometimes surgeons' views about who might be favourable, and actually sometimes optimism and biases. And this, of course, really influences which patients are selected, what the outcomes might be, and then ultimately influences whether the innovations progress and advance through the innovation pathway, or are modified, or are maybe even abandoned altogether. So what we understand is that there's a gap there, and there's a real need for some more practical tools to help utilize the ideal framework, the ideal recommendations around patient selection and adaptation as we move through the pathway. So our proposed solution, we're ambitious, but our proposed solution is to work with key stakeholders from a really broad range of different fields, and to co-develop a framework which is essentially a set of recommendations for safely adapting the eligibility criteria in early phase studies throughout the innovation pathway. And we hope that this would offer some kind of structured and practical guidance which aligns with the ideal existing recommendations. So much like James's checklist we just heard about, it would complement what IDEAL are proposing, but applying some kind of practical tools. And our goals, as I said, we're quite ambitious. This is just a one cog in the machine, but we hope that producing some guidance like this will really support transparent and unbiased evidence-based decisions to either maintain or widen, or indeed maybe even restrict patient selection as you move along the pathway. And in turn, that will generate evidence, which is much needed, of the benefits and the risks in the broadest range of patients possible, which is really important to make sure that our research and our innovating is inclusive. And taking all that together, the main goal, the big kind of end point would be to expedite or speed up promising innovations into that phase 3 evaluation, or importantly, stop the harmful or ineffective innovations becoming widespread just because they haven't been evaluated in the best possible way. So how do we hope to achieve this? So we have the Lotus Design Study, which is a 3-year project that's funded by a methodology grant from the MRC. And essentially it's a mixed method study that we will try and develop the framework initially in phase A, so co-development with the key stakeholders that I mentioned, and then moving into a phase B where we'll test and refine the framework in real world innovation case studies. And the co-development work so far, we've been running the study for just over 6 months. We opened sort of midway through last year. we've been looking at existing guidance, so that includes everything that IDEAL have published, but also with regulatory documents such as HTA recommendations, to collate what should happen in terms of patient selection and adaptation as you progress through the pathway. So intended practice, really. A second work package has been looking at interviews, so exploring what happens in the real world and how those decisions are made in practice about how to select the next group of patients and make changes and adaptations. And then we're doing some consultation work with our stakeholders. So we've held one workshop so far, another one in the pipeline for next month, as well as interviews with our stakeholders to really consolidate and inform the content of what the framework might look like. So we're fairly early days, but this is our kind of initial proposal about what we think the key principles will look like. So essentially the framework or the recommendations will have two components. The first component is all about pre-planning and documenting before starting the set of procedures. So documenting and thinking about your initial eligibility criteria, thinking about how that might change and adapt at certain time points, and then also pre-planning when you might pause and stop and look at the data and look at the patients that have been offered the procedure and look at the outcomes and reflect on that. So that's all documenting and pre-planning before you start. And then in real time, we hope the framework or the recommendations will prompt tools or methods to capture eligibility and adaptations as they're happening, carry out those planned pauses, really review the data and discuss, and to optimize decision making about how to adapt things or modify the patient's eligibility criteria, and to really kind of move away from that siloed innovation model and share learning about what has happened and how things have changed, and then to restart the procedures and repeat the whole process again. So as incrementally as you're moving along the innovation pathway. It might look different, but this is kind of roughly where we think that we are at the moment. And as the study progresses, obviously this might change a bit, but I think for the current state of play, that's a good place to pause and take any questions.
Perfect. Thank
you. Thank you
for
listening.
I think, again, this is brilliant. I think this is a kind of a situation where a lot of biases can get introduced to early stage studies. But talking about the SMART guidelines and the rest of IDEAL, for early phase studies, do you think we run into a danger of having too many guidelines or things to follow? For initial setup, you've got all of your local compliance and governance structures, the ethics, to follow. And if you're a small research team, it can be very challenging to manage just the stuff to get the study kind of even off the ground. So the meta thinking about how and why you're doing certain things in your methodology, even when it comes to patient eligibility, it can be quite cognitively tough to then add on this extra element of research.
Yeah, absolutely. And just like we've had with the reporting checklist, there's already so much out there. But I think the key thing with this patient selection framework or set of recommendations is it's a tool to help. And we are developing it we're co-developing it. So with lots of innovators, with people that will ultimately be using it to try and make sure that it isn't just another tick box or challenge. It's really there to help the whole process and make it easier. But yeah, I do understand what you mean.
Rhiannon, thanks very much for your talk. As a mixed methods researcher and with a qualitative background, you'll understand where I'm coming from when I say nobody's unbiased. And you must start with some kind of conception of why surgeons change the indications for their operations. Or I just wondered whether you feel from the literature or from the discussions you've already have, whether people more often change things to avoid risks or because they think subjectively they've seen a better way of doing things.
Yeah, so absolutely, we have empirical data from the interviews that kind of demonstrates exactly that. There's so many different reasons why people change. Sometimes it's reactive to avoid, harms. Sometimes it's based on the patients approaching the surgical teams and saying, I really want this. And, there's many different drivers. But I think the key thing is, as we said in the slides, like we really want a lot more thought to be put into the planning. And it's not to say that things will be different in practice, but it's to continually pause and reflect and think, well, why has that changed? Why has that adapted? And try and make it much more transparent and look logical, I think, is probably the right term.
So I just noticed that there's a repeated theme of the reporting of refinement learning in each of these frameworks that are being discussed, and especially as a key tenet of the early stages of IDEAL. I looked at the early implementation of a robotic surgery system up in Edinburgh for my PhD. And something I wondered about is the timeline of dissemination in reporting refinement learning. I think it's important to, as we've discussed, avoid the repetition of egregious or like the repetition of maybe very fixable early stage refinements as systems are translated to new contexts or new users. Like the early days of learning should be disseminated. But the question I have is about the timeline of that dissemination and the means of that dissemination. If the coin of the realm is peer-reviewed articles in peer-reviewed journals, how do we catch up to the time frame of translation as it's happening in real time? I wonder if there's a quicker and a dirtier way of disseminating that refinement learning, is what I'm getting at. And I wonder if maybe industry, such as the evaluation or the implementation specialists that I saw from CMR or are stationed in theater, might be one of those possible vehicles to dissemination. Or if anyone has any thoughts about how we can sort of address the difficulty of the juxtaposition between the real-time innovations as they're unfolding rapidly and ever acceleratingly against the delay of academic publication and disseminating those results.
Thanks, Andrew. Yeah, I'm not sure if that's a question for me, but yeah, I completely agree with you. And in fact, in our centre, the whole topic of shared learning in a much more kind of real time is something we've been talking about for a long time now, and developing methods to help facilitate that rather than wait for conferences, publications, and so on. So yeah, I completely agree. And I think the key thing is making sure that there are these kind of meetings with other fellow innovators within that specialty and trying to share knowledge through different tools, really.
Thank you both very much for that discussion. So we'll move on to the final abstract of the evening, which is Dr. Julio Perez Sosa from Mexico City, the surgical redesign with a novel iactro-mathematical model.
Good afternoon. Well, thank you for allowing me to be here. My name is Julio Perez. I am a gastrointestinal surgeon from Medica Sur in Mexico City. Today I will present a conceptual framework that explores whether the operative act itself can be represented mathematically and whether such a representation can help analyze and redesign surgical procedures. Well, let us remember that scientific medical knowledge started looking for causal explanation of diseases. This is called mechanistic reasoning, based on mathematical models. Then, during the 20th century, medicine shifted toward statistical reasoning, and evidence-based medicine formalized probabilistic inference. Today, there is an important convergence that is emerging. The integration of mechanistic, mathematical, or causal models and probabilistic and statistical models. So today we can see that modern clinical science is moving toward structural integration, and not only medical science, all the sciences are moving toward this integration. The most famous example today are the large language models and AI. Why this? Because mechanistic models describe how processes occur, while probabilistic models quantify uncertainty. We made ourselves this question: is the surgery ready for this integration? Well, the state of the art of quality in surgery is confirmed currently by two main pillars. First one, protocols analyze preoperative risk and security steps. And the second pillar, the follow-up and analysis of surgical outcomes. But an important question: what about the middle of the process? What about the most important element, the operative act itself? It remains structurally undefined. There is no formal mathematical or statistical representation of the internal architecture of a procedure or the structural origin of surgical risk. This leads to a simple question: can the surgical act be formally modeled? Formally, I mean inside a formal language like logic or mathematics. Spoiler alert, the answer is yes, but we didn't model it with a single model. We needed five mathematical models organized in layers. Why five? Because different structural properties require different mathematical representations. For example, for modeling tissue memory, when you work in human tissue, the more you work a surgical zone, the more inflammation accumulates and increase the probability of bleeding or tissue tearing. Currently, there is a mathematical dilemma. Is the mathematics discovered or invented? So I believe that we can apply this dilemma here because we are not pretty sure if we discovered or invented these units. But within this framework, we introduce these structural units. I want to focus in the surrogate, the most important one. The surrogate is the minimum formal surgical unit. The smallest unit, it has a discrete interaction between a technical action and anatomical tissue, and has a binary value. It only can be done or cannot be done. There is no middle term, okay? And well, there are other units like surgical steps, anatomosurgical units. And with this, we discovered that surgery really can be discretized and structurally formalized. So then we have here I describe the main parameters of the model, the main ones because there are many. First of all, linearity. Linearity is represents the probability that one planned surrogate follows another. The contrary is the deviation. Deviation describes the likelihood of an unplanned action. Yet the probability that a surrogate will be followed by unplanned. For example, you're in step 3, and in the step 3, you got bleeding, and you must to apply hemostasis. This hemostasis, this specific hemostasis at this moment, wasn't planned. Okay, so this represents the deviation. Then we have the concept of entropy. Entropy, it's very interesting because it's the degree of uncertainty inherent in the surgical process. The more deviation, the more entropy you have in your surgery. And finally, we have the noise. The noise, it's an attempt to represent mathematically the individual variation in every patient. Are patient-related or external factors that increase the probability of deviation from the surgical sequence. We applied this framework to three techniques of Heller myotomy. The classical tearing technique, where there is a tearing in the muscle layer, the submucosal technique, and we made a redesigned procedure called Heller Secure, in Spanish Heller Segura, Heller Secure, which in this technique we added security steps. And we found that structural metrics reveal differences in step linearity, entropy, and the model can identify the presence of security models. The model detected architectural differences that are not always visible through outcomes analysis alone. Here we can see how the model identifies the differences between linearity structure of every technique, with the security Heller the most robust technique, which is compatible with the more secure structure that this technique has. So the model identified a structural fragile component of the procedure. Identify that the first technique leads us to a more probability in complications. We quantify deviation probability and structural entropy within this step, specifically in the step of the myotomy. Based on this analysis, the redesigned technique introduced, the model identifies that this technique introduce preventive security models. So the model therefore not only measures surgical structure, but may also guide procedure redesign. Finally, this model works. We can see that this model works, but this model can be integrated with the current models in surgery. Well, within the ideal framework, I think corresponds to stage 0 and partially stage 1. But Bayesian analysis can also integrate directly within this structure. Mechanistic modeling defines the architecture, while Bayesian inference updates the probabilities within that structure. The same for other postoperative models like benchmarking or Clavien-Dindo, where these models give us the post-surgical outcome, but iatromathematical model explain the steps, surrogates, or architectural structure that explain these results. Well, we believe that if further refined, this approach could provide a structured basis for future computational systems in surgery, and not only computational systems, but a new way to see a new heuristic modeling a surgery. This may include advanced AI applications and digital representation of surgical processes. But why this model? Because has a robust and strong mathematical basis that could be applied and well, must be proved in the real world. In summary, this work explores whether the operative act can be mathematically represented. If this approach continues to develop, surgery may become a domain where structural modeling and probabilistic inference converge within an unified framework. Well, thank you.
Brilliant, thank you. Does anyone have any questions?
Thank you so much for the talk, and I'm conscious we're at time, so I'll keep it pretty brief. I really like the concept, and it chimes with lots of work being done in the wider literature to try to structure the language in which we use to describe surgery. But the convention, particularly in the surgical vision computer AI literature, is around phases, steps, actions, gestures, and having a triplet where you describe the anatomy, the instrument, and then what the instrument is doing to the anatomy, so the action or gesture. So you have a triplet to describe what's going on in surgery. When you talk about a surgeon, what exactly is that? Is that a spatial interaction between the tissue and the instrument? How would that, I mean, maybe I've just misunderstood it, but I'm trying to pull these two things together.
Yeah, I'm sorry, I'm explaining it very quickly, but the surgical unit, it's the minimal action that cannot be separate into more steps. Yeah, for example, we need to cut a tissue, okay, with no vessel, a tissue with no vessel. We can follow the next step, okay? So in this step, you only can cut that tissue or not cut that tissue, but there is no a middle term. You cannot cut the half of the tissue, because this means that you didn't finish this action, this surgical action. That means the surgical unit. It's the minimal unit of action, yeah, that we, the surgeons, make during the procedure.
Right. I mean, and perhaps we could take it offline. I'm still not sure I've got that straight to my head, but I'll let others have a chance. Thank you. Thanks, Julia.
Thank you for this interesting talk. And I was just wondering, how much data would you need to model such a surgical procedure?
Well, we started with 5 surgeries, but we believe that every type of surgery, every kind of surgery needs their own data for modeling, because it's very different as a gastric bypass from a Heller myotomy. Yeah, and we made an estimate of like about 10 or 20 surgeries. It's not much, because already has a robust mathematical basis, and we are moving away from statistical analysis. So we don't need a huge amount of population for modeling.
All right, thank you.
Okay, thank you. Like Hani said, I'm just mindful of time, so we'll hand over to Professor McCulloch to leave us with some closing remarks.
Thank you very much, Hugo, and thanks to all the speakers and the attendees. I'm very happy with the way this is played out as our first springtime online meeting. Hopefully this is going to become a standard. Particularly as we go forward, I think with Hani taking over the chair, we now have, if I may say so, a much more business-like and organized approach within the group. And we have access to his very impressive setup in neurosurgery, which means lots of potential examples for working on IDEAL. Hopefully most of the audience appreciate that IDEAL is essentially an attempt to change the paradigm in evaluating surgical and other complex interventions. And paradigm shifts are difficult. They take time, they take diligent, methodical work, and I would point to the excellent work presented by the Bristol Group as part of that. And eventually things tip. But things tip when policymakers get the message that they need to change. And for that, we need lots of people to join us in IDEAL and evaluate the evaluation system. So I would give you a big plug for our advisory service, saying that if anyone has examples of surgical innovation that they would like to study using IDEAL and are hesitant about it, please get in touch. Final plug is that our autumn meeting will be in Oxford on the 9th and 10th of November, so keep an eye out for that and please sign up early. Thank you very much, everyone.